Well, hello, everyone. The Urban One family is proud to present, in conjunction with Johns Hopkins Medical School, Straight Talk on prostate cancer. We're moving beyond the controversies and empowering Black men today. And I am so excited. Please share this link with someone that you love. Let people know what's going on right now. This conversation can literally save somebody's life. And we have a powerful group of panelists today, experts in their field. And I want to introduce to you, my name is Keith Battle. I am an author and the founding pastor of Zion Church. And I want to introduce our panelists today. First, we have with us Mr. Robert Carey. Robert Carey is an advocate in the space around cancer treatment. He sat on a board of advisors of cancer research. He is also a 25-year cancer survivor himself. And we welcome you today, Mr. Robert Carey, to the panel. Thank you for being with us.
Thank you for having me.
And we also have Dr. Clayton Yates with us. Dr. Yates is a professor of pathology and oncology at Johns Hopkins University School of Medicine. He also serves as professor of biology at Tuskegee University and is internationally recognized as an expert in prostate cancer health. Thank you, Dr. Yates. It's an honor to have you with us today.
I'm happy to be here. Thank you for the invitation.
Yes, and Dr. Curtiland Deville is with us as well. He's the medical director of Johns Hopkins Proton Therapy Center. He is also an associate professor of radiation oncology and molecular radiation sciences at Johns Hopkins University School of Medicine. Dr. Deville, thank you for joining us today.
Thanks for having me.
And finally, Dr. Otis Brawley is with us. He serves as the Associate Director of Community Outreach and Engagement at the Sidney Kimmel Comprehensive Cancer Center in Philadelphia, Pennsylvania. Dr. Brawley is also a Bloomberg Distinguished Professor of Oncology at Johns Hopkins University. Dr. Brawley, welcome and thanks for being with us today.
Hi.
Each of you. Dr. Brawley, I heard you laughed. You good there?
Yeah, I'm at the Sidney Kimmel Cancer Center at Johns Hopkins in Baltimore, not Philadelphia.
In Baltimore, not Philadelphia. Got to get my source right.
There are two Kimmel Cancer Centers.
You're at the one in Baltimore. Well, great. We're glad you're here with us today. And let's start this off. Mr. Carey, you have a personal story of experience. Can you briefly share your experience with prostate cancer?
Yeah, I'll be happy to do that. And my journey with prostate cancer started roughly 27 years ago. And the fact that I'm sitting here talking with you folks this evening, I believe gives testament to the need for early detection. So that is one of the things that when I'm working with support groups, individuals, that I will focus on that quite a bit. The other thing is that my story actually began when I went to the doctors for just a checkup. And the doctor told me that my PSA was elevated. And I said, okay. And I left. And several months later, I saw him again at a different setting. And he asked me if I had seen a urologist. And I said, I'll get around to it. And what I neglected to say was that I really wasn't sure what PSA was when he told me. And I didn't think, I said, well, he didn't put a lot of emphasis on it, so it must not be that bad. So I kept moving along. The second time I had the conversation with him, he was a little bit more aggressive, and he gave me the name of a urologist and actually called a urologist and asked him for a time when I could come in and see him. So that's how I got my appointment with the doctor. And after the testing, the digital rectal exam, it was determined that I did have prostate cancer, but it was in the early stages. And 27 years ago, there weren't the options, I believe, that are available today. So my wife and I elected to go for surgery. I was told that remove the prostate gland. If it hasn't spread beyond the cavity, then it'll be like you never had it, never had cancer. And that was true. Once I had the surgery, I went through a short recovery period, which I would have to say was amazing and a blessing. There were, some things that I had to do, but after about 60 days or so, everything settled down, and I have not had any issues with cancer or side effects up to today. But during that time, what I did come up for me was the thought that if I didn't know, and I considered myself fairly intelligent and up to date on stuff, but if I didn't know what PSA was and I didn't know the importance of it, then there are other men out there who don't know. So I
Yeah.
decided to create and facilitate a focus group, support group, I'm sorry. And I did that for several years in Atlanta and working with Crawford Long Hospital, where they gave me some of the space to run the support groups. And I have to say that some of the topics that drew, or one of the topics that drew the most attention and got the most men and their wives and girlfriends in was the issue of impotency. That once you had cancer, that was the end of your sex life.
Well, wait,
And
Mr. Carey, before you go there, let me cut you off for a second, because you're using terminology that I think part of the problem is we just don't know what we don't know, and your experience has told us this. So let's doctors, I want y'all to give us a PSA, a public service announcement on a PSA. What is a PSA, Dr. Clayton Yates? And then I want to go to Dr. Deville and talk about what is the purpose of the prostate gland. Is it a gland? So PSA first and
Absolutely.
foremost.
So PSA stands for prostate specific antigen, and what it is actually very unique. It's a molecule that's secreted by the prostate, and it specifically determines what's happening at the metabolic level. So we talk about with your prostate biology, what's actually going on with your cells. And is your prostate growing or is it not? And it's a marker of the growth and or the physiology of what's going on in that gland. It's actually highly specific for the prostate. We haven't found any other organ to secrete PSA, and so therefore is used to determine activity that's going on in the prostate gland.
And that prostate gland's purpose is what, Dr. Deville?
Got it. Yeah. So the prostate is a small gland that sits, it's about the size of a walnut, that sits at the floor of the male pelvis. And get a little bit clinical just for folks here briefly. But it provides mostly a fertility function for men. And so it secretes one gland, a big gland that's made of tiny, small glands, secrete fluid. And that fluid actually joins the semen in the ejaculate and provides a fertility function. So, when it's going off to wherever it needs to go to help with that process. The issue is that as men get older, we sort of lose that fertility need and function. And where the prostate is located, because it surrounds the urethra, which is the tube that drains the bladder, from the urine. So, when we urinate, the urine's coming out of the bladder through the urethra, and it kind of surrounds the urethra. And it can grow is just a sort of normal, kind of normal process in men as we age. And that can kind of obstruct or block off the urethra, and that causes a lot of trouble with urination. So folks are sort of commonly hearing about, men as we age, we have urinary problems, we might be going more frequently, we might not be emptying as well. A lot of times, in fact, most of the time, that has not to do with prostate cancer and just with that enlargement of the prostate gland obstructing the urethra.
So to that point, when Mr. Carey got this information, Dr. Brawley, when he was told his PSA level his number was high, and he kind of dismissed it because we don't even know what a PSA is. Why then? Okay, well, let me ask it this way: is it possible to have a high PSA and it not be signs of prostate cancer?
Absolutely.
And then, so that's possible. But why is it then that we have this disparity amongst Black men, where we are so prone to have to have prostate cancer and actually deaths associated with it? Let's talk about that.
Yeah, okay. Well, if I can add one thing real fast, there are a large number of Black men. This is a bigger problem than prostate cancer, actually. A large number of Black men in their 50s and 60s and 70s who have difficulty urinating, who don't go to the doctor. And they really should go to the doctor because we have medical treatments and some surgical treatments when necessary to help men get some relief. And I cannot tell you how many men I have encountered who are having problems. It's not prostate cancer, it's a benign prostatic hyperplasia or BPH, and they don't go get treatment. If we can get that message out, that would be important. Now, yes, of men who choose to get screened for prostate cancer, and we must say that the professional organizations of doctors have said men should know the potential risks and the potential benefits of PSA screening and make a decision as to whether they want to get screened. And those who want to get screened should be able to get screened. If the PSA is over 4, we generally are going to want to do some additional assessment, and that may very well be with an ultrasound of the prostate. It may be with an MRI of the prostate, and it may also involve biopsies of the prostate, sticking needles into the prostate and getting some tissue. And in answer to your question, somewhere around 1 in 4, 1 in 5 men who have an elevated PSA will be found to have prostate cancer.
Okay. So how old, at what age should men start getting tested?
The professional organizations, that's the American Urological Association, the American Cancer Society, they say that men at the age of 45 to 50 need to make this decision as to whether or not they want to start a program of screening. Program is really important. It's not a one-off. So frequently people go just get it one time. If you're going to get screened, you need to get it every 1 or every 2 years routinely. And so if you have a prostate cancer family history, we recommend that you make this decision 10 years before your brother or your father or your uncle got prostate cancer. So if they were first diagnosed at the age of 47, you need to start at 37. If you don't have a family history, you need to start making this decision somewhere between 45 and 50. By the way, most men who are diagnosed with prostate cancer are in their 60s. The median age at diagnosis is actually about 63.
That's important to know, that especially about that family history, and because we don't talk about it, some people don't even know, right? So let me ask you guys, and any of you can answer this: why do you think the disparity exists, first of all, and what can we do to mitigate the disparity amongst this problem amongst Black men?
If I can handle that first, there are 2 disparities we need to talk about. One is Black men, especially Black men from northwestern sub-Saharan Africa, are more likely to get prostate cancer. Interestingly, Black men from Southern Africa, Eastern Africa, they may have lower rates of prostate cancer than white men from Europe. But there is a large number of Black men.
Why so? Why do you think so?
Well, there are a number of diseases that vary by area of geographic origin. If you want to talk about cystic fibrosis, that's a high amount of disease of people from northwestern Europe, from Belgium, the Netherlands, Denmark. There are a number of diseases that are like that. I don't know why. But
they have a geographical nation.
Area of geographic origin is more important than race, but we don't walk around with, I got my chromosome 17 from Ghana, or I got my chromosome 17 from Germany. But in any event, there is a higher risk among Black men in the United States. Remember, a large proportion of us are from Northwestern Sub-Saharan Africa. That's the slave trade. That's one issue. Black men are almost twice as likely to be diagnosed with the disease. But another incredibly important issue is, once diagnosed, equal treatment yields equal outcome among equal people. Okay, Black men and white men have the same prognosis at the same stage. Now, that's really important, because a large number of Black men, and this is, people always talk about screen. A large number of Black men who are diagnosed get less than optimal therapy. And if they get good optimal therapy, their chances of doing well are just as good as any white man who has this disease. So one of our messages needs to be, go out there and seek good therapy.
I want to, Mr. Carey.
Can I add to that a little bit?
Absolutely, Dr. Yates, go ahead.
Yeah, so I think Dr. Brawley set up a really great sort of topic, and really, there's been an explosion, I think, of biology around what Black men. When I say Black men, Dr. Brawley also said, we can't talk about Black. We really got to think about genes, locations, origins, and so forth. And if you start to look at this explosion, particularly in Africa, even myself, we've gone to Africa several times, sort of trying to map if there is a prostate cancer gene. There are some geographical differences that we see in the genetics of men from South Africa, from Northern Africa as well, from the Nigerian, that also translate to the population genetics that we see here in the U.S. as well. So there is some type of, we have the whole diaspora in the transatlantic slave trade that sort of, that mitigates some of these processes that we see as far as the incidence of disease here in the U.S. But we're starting to find that be associated with an ancestry-associated phenotype that is an origin from either North or Southern Africa.
So back to the, this getting equal care, quality care, leveling the playing field. Mr. Carey, what kind of work, where can people go? Like, is there a website? Is there a place people can go to level the playing field of treatment in your advocacy work that you're doing, so that we get similar results because we're getting the quality care that we need?
Well, in talking with men in the support group, that question came up quite a few times, many times. Where do I go, and will the insurance cover it, and will my friends and family know that I'm doing this? So we would recommend that they first go to their personal physician, talk with them, and then go from there. But it's been, over the years, many different programs that have been set up to give men the information they need to go where they need to go. So if they go to the American Cancer Society or someplace like that, they can be directed. If they go to many of the hospital have cancer centers, and they can get information there. Not only can then they get information about prostate cancer, but their wives and friends can get information if they so desire. They can get information about other types of cancer. So encouraging them to be tested, even if it's just a conversation to find out if they need to be tested. And this type of conversation that's going on, as you said earlier, I mean, it's critical, and it needs to take place with Black men. And we have a habit of not really talking about some things. So yeah, I have two sons, and prior to my experience with prostate cancer, honestly, we never had any talks about health issues since we've had many. So
Yeah.
a little bit of knowledge and then spreading it and sharing it.
Yeah, I think pain opens us up to having those conversations because they become preventive and protective. Like, I need to tell you this because this could happen to you. Dr. Deville, did you want to speak to the disparity piece before we go into screening and diagnosis? That's where I want to tackle next. Any thoughts on the whole disparity issues?
Yeah, absolutely. And I think it will lead into kind of those next conversations. I'm sort of on the other end of the spectrum from Dr. Yates, where, in the sort of clinical management and the access to care piece and thinking about disparities from that angle, we really see that, how we end up with the disparity in outcome being, Black men twice as likely to die from prostate cancer than white men is, if you think about, the entire continuum of care from from screening to workup to your sort of staging, the imaging that you get, the the treatment options that you have, whether you get treatment, whether it happens in a timely fashion, if there's delays to care, what's your follow-up look like? How are you managing follow-up? Are you having appropriate follow-up management then? And really, at all of those time points, we can see differences. We can see disparities that if someone is not getting appropriate and equal and equitable care, that their likelihood of having a as good outcome is going to diminish. And so we really need to be thoughtful at all of those points where we're accessing and when we're guiding patients through their sort of cancer course and through survivorship, that we're thinking about and paying attention to that. And so, from that perspective, patients and family members and caregivers can empower themselves to be thinking about and paying attention to that too, and advocating for themselves, and much in the way that we advocate for ourselves in many other environments. But somehow, when we're thinking about healthcare and cancer and screening, sometimes there may be uncomfortable, discomfort or just unknowing that we really need to advocate for ourselves in our communities, which is, what we're doing here today.
Yeah, you said something that triggered another series of questions for me, and that was delay in care. Because anytime I hear somebody says they got cancer, they say they have cancer diagnosis, and they're waiting, right? Well, I'm waiting to hear back from this, and then we're going to get this done. And I'm always thinking, wow, the clock is running, right? So what it brings up, and this is kind of a question of vulnerability, because in my world, clergy got overwhelmed by the pandemic, right? Just, the mental health challenges of people. We're to be therapists, all of that stuff. Has this become such an epidemic, the prostate cancer issue, that you guys are in a place of being overwhelmed by it? And that's part one. I hope that's not too forthright of a question. And then the second one, can you explain the delay in care? Is there like a triage, like, somebody gets in first that, because it's more urgent? Like, on this side of it, just being on the patient side, it always seems like people are waiting to be seen, waiting to see what the process is. And I know you are, hey man, I got 20 patients. Kind of take us inside of the room of what happens on your side of it. Is it overwhelming? What is the process while that patient is waiting? What's happening? Give us an inside look, if we can, of what's going on in any of you who are tracking with me on that question.
I can start to address it, because I think I can hopefully clean it up a little bit. I think we can think about this from a lot of different angles, and there's going to be patient specific variables. There's going to be kind of provider, the interaction with the provider, the health system level, the insurance, policy, things that all of these variables that might lead to delays in care. But one example is actually what Mr. Carey shared in the beginning of his story, of where he had the initial elevated PSA. And then, some time passed and he went back to see the physician later, and the physician asked, had you pursued that, referral or seen that other doctor? That is, a potential delay in care, something that could have been addressed sooner. And we know that our outcomes with any cancer really is always better the earlier that we catch that. And so, we don't want to have unnecessary delays in care. I think, to answer kind of the other questions that you were asking there, I think we try to do a good job. There can always be, again, barriers in the system to getting people in. But we really do try to get folks in a timely fashion. Most cancer center, have goals and metrics that they're looking at to make sure that they're available and getting patients with new diagnosis in a timely fashion. And we do triage, for example, we'll talk about aggressiveness of prostate cancer and what we call the Gleason score as a measure of the aggressiveness of the cancer once it's been diagnosed. That may triage, how quickly you get them in, but also their treatment when they're actually getting treatment, how quickly you'll get them in, say for a surgical procedure and those sorts of things. So I think we work to mitigate those, but again, everybody can be their own advocate and really be trying to prevent these unnecessary delays in management. And much like anything else, if you speak up, if you're reaching out, if you're making that call, that's going to help you, address these issues more quickly.
That's good to know. Duly noted. Speak up.
Yeah.
Dr. Brawley, I know you want to chime in on that, and I want to.
Yeah.
I also want you to go back, in addition, and readdress the screening issue, because you talked about not being a one-off. So I want to go into screening and diagnosis. So
Okay.
wherever you're going with what Dr. Deville said, make sure
Let me
you
follow up on Dr. Deville. I'm the older guy here, so I can take hits for what I'm about to say. And I also treat prostate cancer and study outcomes in prostate cancer treatment. In the United States, and I'm going to give you some examples.
Mhm.
I know of one man who knew he had prostate cancer. He was diagnosed in 2011. The next time he came to see a doctor, it was 2022. Okay? Now, there are a number of social reasons. I don't want to blame him, but there are a number of social reasons, insurance, job, and so forth, and not knowing, fear, that kept him from the doctor. That's bad treatment. There are a substantial number of men who get treated by doctors who only treat, they're surgeons, but they only do surgery on 5 or 6 prostate cancers a year. We got data to show you get a better surgery from somebody who does 5 or 6 prostate cancer surgeries a month. Okay. Dr. Deville has published data to show that poor people, this is not just for prostate cancer, but for other things, have a tendency to be treated in centers, and tell me if I'm wrong, centers that have older, lower energy, if you'll let me use the word, more dilapidated radiation therapy machines. Okay. Now, most people who get radiation therapy don't ask, what's the make and model of your linear accelerator? But there is a difference in quality. Some of these are more socioeconomic than race, but unfortunately, Black people tend to be lower socioeconomic. So and let's hit my area, which is chemotherapy and hormones. We find that the doctors who take care of a lot of poor people will underdose the chemotherapy. They underdose the chemotherapy because they don't want to deal with the side effects of high-dose chemotherapy later on. But the phrase that we use in my business is you're killing your patient with kindness, because we know the higher dose works to treat the disease, the lower dose we don't have data on. So those are some examples of lack of quality care.
Wow.
Now, you were asking about screening.
No, you got it. You just dropped a bomb, right? And this is, to me, it is ignorance that is dangerous for us. It is not being intelligent in this space that's killing us. And you're giving, and I hope people are sharing this link. I hope this is being recorded. I hope it's being shared with people, because now I want to get you all 3 of your numbers. And if I ever get it, I'm calling all 3 of y'all and saying, hey, yeah, I got, and Otis Brawley is on his way to meet me at your appointment. Like these are the things, like knowing the speed of a radiation machine and the doses of chemotherapy. Like, how many families are unaware of this?
Yeah.
And we're praying people too, if I might add, right? And we're going to the pastor and we're asking the church, please pray. And faith faith is a big part of I think of our treatment, our faith. But we need good treatment as well, right? Because that just was such a profound statement, and it may not be news to you all, but it just rocked me to my core to hear that so made so plainly. And I hope we keep that out in front of people. We have to be educated. We have to be in there asking questions. We should that's why I wanted this is high shelf information, put it on the low shelf, right? So that we can walk out of here empowered, knowing what questions to ask, knowing, it's the doctor's responsibility to explain this to us. What are the pros and cons of a higher doses of chemotherapy? So thank you for sharing that. I had to give some pause to it before you go into screening and diagnosis. And I know we're running out of time, so we got to get to that as well. How does that work? The screening and diagnosis process. Can we combine those two things,
Sure.
Dr. Yates? Oh, okay, good.
Sure. A person who wants to be screened, and keep in mind the professional organizations say, talk to your doctor about the potential risks and the potential benefits, make a decision as to whether you want to be screened. If you want to be screened, you should get it at least every 2 years, perhaps every year. And screening involves a gloved finger being stuck up the rectum to feel the prostate, as well as drawing this blood test called the prostate specific antigen, or PSA.
And that's the needle.
That's the needle in the arm. Right.
And that's the one that. So let's talk about that. You were very transparent about some of the disparities in treatment. That's probably the one that people are avoiding. The glove and the Vaseline is, we can get away with. Did you talk about sticking?
Not
and I hear
really.
stories. What are we doing here? What are we? Will you say, Mr. Carey?
You said the glove and the Vaseline we can get away with. Not necessarily. I think many men are more will avoid that more than a needle.
That's my experience too, sir.
That's our experience as well.
Oh
yeah.
my God. Are you serious? I'd take the glove any day over the needle.
Well, you would out of 10 men, you might be one of 3. And I have nothing to back that up other than what I've heard in support groups, in counseling sessions and things like that. And to the extent that, the comment that, I'll die before I let somebody me.
Yeah, I got you on that.
And
Okay.
I say they truly are dying because, we're
Yes.
dying early because they're even missing the entire physical, annual physical, because there's so much apprehension around the thought that I might need a digital rectal exam. So I think, a key piece is don't let that be your barrier to your overall health. They're not even going, you're missing out on your blood pressure and cardiovascular screening and all other things just because there's so much fear around that, fear and stigma, probably more than anything. So I think, we do still need encouragement. Don't let that be the barrier to your own health,
Right.
because it's leading to a host of bad outcomes, not just prostate cancer.
Hey, I want to go to a question from our audience. We got one from Will Epps, who's watching, and he says, are there any preventative things we can do to protect the prostate health? Natural products, supplements. Let's talk about that. I know it's a term, but let's talk about that.
Yeah, I would be careful in terms of these supplements advertised on TV. If you watch the entire commercial, they always say not evaluated by the Food and Drug Administration, not FDA approved. I'd be very, very careful in taking some of those. I can go back to other diseases. A few years ago, back in the 1990s, we actually did studies of high dose vitamin E because we thought it prevented some disease, and we found out that it caused stroke. High dose selenium increases risk of diabetes. High dose beta carotene in smokers increases risk of lung cancer. So I'd be careful of these things that have not been evaluated. The best you can do is 5 to 9 servings of fruits and vegetables per day, regular exercise, maintain an ideal body weight. And by the way, we haven't talked about this, but even before you start talking about prostate cancer, don't smoke, get checked for diabetes, get checked for hypertension, and get those things treated if you have those.
Anyone else on this preventive care?
I think Dr. Brawley explained it very well. If you were to take a vitamin, I think the most evidence for prostate cancer we do have, particularly in Black men, is vitamin D. There's been a number of studies come out, more recently, even stuff published from my lab, vitamin D treatment. Again, we don't want to say treatment here. We talk about preventive, healthy lifestyle or healthy living, right? Just trying to keep a healthy prostate. We've seen it sort of mitigate some of the anti-cancer activities that we know.
I'll join Dr. Yates. A vitamin a day, a daily megavitamin.
Yeah, so just your multivitamin is definitely helpful. Yeah, absolutely.
That's fine. We're talking about people who take large amounts of vitamin C. Or
no,
that's bad.
Yeah, no, I'm just adding one little bit of a tidbit of specifically the vitamin D work. There's been a lot of work around prostate, particularly in Black men, and that seems to have some better effects. But again, you want to regulate that. But I also want to caution people, because people also ask, well, can that treat my prostate cancer? That is not a surrogate for treatment. Okay.
Yeah.
Right. That's not a surrogate for treatment. So we're talking about prevention. We're talking about maintenance of prostate health, not preventing prostate cancer disease, treatment of prostate cancer disease.
When you get to treatment, so we kind of jump some stops, right? So we treatment is present because we've now got a diagnosis, right? One of the treatments that I had a friend say, I'm just going to be on monitoring, right? Nothing, we just on monitoring. So we like that. It's kind of like, yeah, I'm good. I'm just monitoring. Let's talk about monitoring and other forms of treatment, and the risk, what goes with what piece goes where. This diagnosis gets this treatment. Put the puzzle together for us, guys.
Kurt is really good at this, but I'll just say about half of all American men with screen-detected prostate cancer today are monitored and not aggressively treated with surgery or radiation. And most of them will never have to be treated. If prostate cancer were a cat, there's tigers and lions, and there's pussy cats. Mm-hmm. And there's a whole bunch of prostate cancers that are never going to kill the man. So we just watch them very carefully. And then there's the lions and tigers that Kurt is very good at treating.
Yeah, exactly. So to build off from that, so the key, step one is, does this cancer need treatment? And so what we do as oncologists is we stratify, that cancer. So first we have to diagnose it, and then we have to classify it. Has it spread or not spread? And if it's not spread, what's the level of aggressiveness? If it's a very sort of indolent, as Dr. Brawley says, the sort of the pussycats, that's the category that we call low risk. So we're going to classify as low, intermediate, or high risk. And that low risk group is really the best group for that active surveillance monitoring strategy, always emphasizing the active part, right? Not the go away and come back when you want to, or, because by then it's often sort of too late in the sense of, our outcomes being as good as they want to be. So we also don't want to miss that window of opportunity to have those best outcomes. But if it's deemed as more aggressive than that active monitoring group in the intermediate or the high risk groups, where we're concerned that this is the type of cancer that could cause death within your normal lifespan or cause you a lot of symptoms and problems, that we need to treat it up front, that's where we then start to go through what are the range of treatment options that we have available for this cancer. The two main curative treatment options being surgery and radiation. So a lot of times if I'm seeing the patient in consultation, I kind of tell them, we have the surgery road and you have the radiation road. And generally, we think that the outcomes are equivalent. You have equal success, whether you take that surgery road or the radiation road. But the logistics are very different. Surgery's in an operating room. There's a major recovery. Radiation, it may be sort of more conducive to, it's outpatient. You can continue your daily life, but you're going to have some short-term side effects and you'll have some long-term side effects. And that profile is a little bit different. And so walking through men and seeing, what are you a candidate for? And often I'll tell them, it's kind of like you're going to have a menu of options. We may not end this conversation by saying this is the one best treatment option for you. It may be that, hey, you have these 2 or 3 options. Now let's take this what we call this shared decision-making approach and realize what might suit you better. What am I hearing from you? Because men will flip it to me, at the end, we walk through everything and they'll say, well, what would you do, right? Or what would you do for your father? Well, I like to say what my father would do is very different than what my uncle would do, right? Each man is different. One might say, I want surgery. I want to get it out, like Mr. Carey was saying earlier. And another might say, hey, I'm not too excited about surgery. And if I can avoid the operating room, I'd rather do that. So let me hear about these different radiation treatment options and schedules. So, having, really you want to be having a good consultation with your oncologist, with urologist, with radiation oncologist, if you are to that point of needing treatment for prostate cancer, and making sure that all of those options are being presented to you, or asking questions like, are there any other options if only one thing is being presented to you? And then we always encourage, folks, get a second opinion. There are many what we call multidisciplinary clinics. We have one at Hopkins. Other, large academic centers have them as well, where I call it sort of a one-stop shop. You can come in, we review all your information, the pathology slides, our pathology colleagues, Dr. Yates, they're reviewing the information in real time. Our radiology experts are reviewing the MRI, the PET scan, things in real time. And then we can come together as a group, Dr. Brawley, myself, the urologist, make a consensus recommendation on, hey, here's what we see as the best options, and provide that information to the patient during that visit. And then they can decide, am I staying here for treatment? Am I going back home to my community? But at least have some reassurance around the recommendations that are being made. I think that's how we truly get to what we were talking about earlier, ensuring that the highest quality is there, the highest, that equal care is actually being presented. And not necessarily just going by, the sort of first thing you hear or the first recommendation you make. You do have to, do your due diligence there and making sure, do your research and feel comfortable with your decisions. And don't worry about offending your physician, your providers, or anybody about that. Sometimes I hear those things too, is it okay if I have a second opinion, or my urologist doesn't know I'm here? And that's, we should have good relationships with our providers and not be concerned about things like that. Otherwise, we can't truly get the best care that we need and make sure that we are accessing care.
Yeah, I should add that things have changed over time. Dr. Yates and his basic science colleagues and the pathologists have developed a number of tests to help us figure out these prostate cancers that are indolent, or I call them pussycats, versus the ones that are more aggressive and actually need to be treated. If you were diagnosed with prostate cancer just 15 years ago, you were very frequently told, if you were diagnosed on a Wednesday, you were very frequently told you need to start treatment within the next 10 days. Mm-hmm. Nowadays, literally 50% of men in the United States who are diagnosed with localized prostate cancer, their first treatment is observation. And it's not doing nothing, it's truly observation. And they will never get, the majority will never get aggressive treatment like surgery or radiation.
Mr. Carey, in your group, your study groups, the groups you meet with, what is the biggest fear of treatment beyond the glove or needle, just going all the way, somebody's got the potential or actual prostate cancer diagnosis. What are you hearing as the biggest deterrent to aggressive treatment?
I would say this was early on for me in the support groups. But one of the biggest really was the loss of sexual being sexual.
It took us 46 minutes.
Intercourse.
46 minutes.
It came down to that many times.
Yep.
Right behind the DRE was, you mean I won't be able to get an erection?
Yep.
And in the meetings, there wasn't just, men. There were women who voiced the same concern because they didn't know. So whenever we had experts, doctors to come in as speakers, that was the number one topic that folks wanted to hear about. You know, what's going to happen? Am I going to have to wear a bag, you know, because, you know, a leakage? You know, am I going to have follow-up surgery because of this? So there are all kinds of questions and fears that come up, and how the individuals handle that fear. It's different from one person to another.
So when that's on the table, doctors, whoever is going to respond to this, when that's on the table, and a man is facing the possibility of losing his life, and he's saying, "But what about, you know, I'm not going to be able to control my urine. I'm not going to be able to have an erection anymore." How do you? I was in a situation this summer with somebody that had a tremendous loss, and I asked the doctors, "How do you consult somebody in a situation like this?" And their response was brilliant. It was like, "Okay, this is what I tell people in a situation like this. What do you tell a patient in a situation like this that's choosing between their virility and their life? What do you tell a patient?"
Well, I can start. I mean, and I lost a little bit of what Mr. Carey was saying, but I got the gist there, I think, in terms of your recap, because frankly, these are the conversations I have day in, day out, you know, every single day in the clinic. And every patient is different. So I think, one, we need to get an understanding of what are their priorities. What do they prioritize? Because sometimes it's not, and very often it's not so clear cut, black and white. You know, we have treatment recommendations. You have various treatment options. We can talk about, sometimes there's a need to add in hormonal therapy, for example, with radiation treatment, which is temporary suppression of the testosterone, because prostate cancer kind of feeds and fuels off testosterone. And so studies have shown with men who have aggressive features that if we temporarily suppress or take away testosterone from the body, that they may, that we can be more effective in curing their prostate cancer and improving their survival. And sometimes men have a hard time with that. Okay, you're telling me for 6 months or a year or 2 years, I'm not going to be able to have a libido, sex drive, and erections. And so we think, you know, we kind of need to balance, you know, and saying, you know, this is our best recommendation in terms of maximizing your survival, but there may be quality of life, you know, impact. And, you know, most men, I think we can help them get to the place of understanding and, you know, figuring out, how do we mitigate these issues? How do we balance? How do we, you know, help get them through this sort of difficult period? But it's really, I think, about weighing what's important to the man. Sometimes if we're deciding, for example, between surgery and radiation, there's an issue of leakage and incontinence versus frequency and urgency of urination, and in terms of surgery versus radiation, and trying to figure out what's more important to one individual versus another. So I think a lot of what I was hearing from Mr. Carey is just the fact that more often these things aren't being discussed, right? The opportunity is not being provided, that where people feel like they were really fully informed going into the treatment and understanding those treatment options. Because frankly, it takes a long time to talk through all of these treatment options and the side effects and the short term and the long term and the follow-up and the survival rates. These are not quick conversations. I mean, this is an hour, 60, 90-minute, you know, consultation that we have to do. But really having, you know, patients need to feel like they've had that experience and that information, and they may need a repeat of it, a refresh, you know, send more questions. And, you know, we as providers need to provide that opportunity. And again, patients and their families and caregivers need to make sure that they're walking through all that and feel really fully informed, so they don't have that regret down the road or feel, you know, upset, or that they weren't like truly informed of this potential. But I think that's where the patient advocacy, those groups, that's where they get to talk to each other and say, hey, did you hear about this? Did you ask about that? That can also be very empowering to help men understand, okay, let me go back and ask about these questions, so I really understand this surgery versus radiation decision, or how this hormonal therapy is going to impact me.
Yeah, my experience is that older men are more concerned about the urinary problems, which are both leakage and urgency. Although there's some older men concerned about impotence as well. Younger men tend to be more concerned about sexual function. And as Kurt says, the only thing you can do is have an open, honest conversation about these things, about what the odds of these things happening are. And then respect the man's opinion. And I've had men who have heard the conversation and decided that they did not want to get treated, even though I felt they should get treated. My job then is to respect that decision.
Yeah. Anything additionally to that, Dr. Yates?
Yeah, I want to add, I think Dr. Deville touched on something about the patient advocacy groups. I mean, I think this is completely underutilized in prostate cancer, particularly with men, or just men in general are underutilizing the resources. I happen to study breast cancer as well, and some community health organizations. The women talk about what's going on with their bodies. Okay, they talk about it. Something doesn't feel right. They go and ask questions to other women. They don't. As men, we have this. Mr. Carey, I think you brought that up as well. We have this sort of fear, and I've done a number of these in person where guys will, not even want to talk about their prostate or some of these, erectile dysfunction possible issues until we get to the food and the cake. At the end, we don't want to ask the question and open. So as men, I think we have to sort of own up to this and utilize the resources available. Absolutely, there could be more, but there are people that have gone through this before you and that are going through it with you at the same time. Take advantage of that. Your physician only has so much time. All right, they only have so much time. You're going to have additional questions outside of that, and you're going to need to reach out. But I think as men, we need to, I want to say, man up and own our health.
There's a couple of questions that are coming in. That one from Stan Richards. He says, "How does stress of life play a part in prostate cancer?" Any thoughts on that?
I don't know is the answer. People look at stress and hypertension, stress and diabetes, but stress and cancer, I've not been able to find a link, although there's certainly some advocates for it out there. I don't think the science is solid. What do you guys think? Clayton, Kurt?
Yeah, I'd like to take the question from a little bit different angle, maybe how it wasn't intended. But I think when we're talking about, how we access care and show up, I think I see people that have busy, stressful lives are often, sort of easy to ignore our overall health. And especially if you're sort of trying to fit your prostate cancer diagnosis, workup, management, and treatment into an overly stressed, busy lifestyle, that's where we see things competing and folks not doing well, missing appointments, delays in care, having a tougher time with treatment. And so sometimes I think a lot of conversation I'm having with men in the beginning and through their treatment and even in follow-up and managing anxiety and things and worry about how to cope about, risk of cancer coming back and those sorts of things is, just our overall stress management and how we're thinking about that, not sort of interfering or competing with this process, but so that we are addressing it appropriately and again, setting ourselves up for the best outcome.
You just a ditto, Dr. Yates?
Ditto.
Hey, somebody from First Baptist Church of Highland Park says that they did a HIFI. Is that HIFI? What's it called?
HIFU.
HIFU.
It's HIFU.
Oh, they so their treatment, their side effects is they can't spell. So you need to check your doctor and get your vowels together. So the HIFU treatment value. What are your panelists? What do you all feel about HIFU?
Yeah, I mean, so HIFU is a high frequency ultrasound ablation. There are a number of non-surgical, non-radiation treatment options that we think of as they can actually be whole gland, the entire prostate, or focal, sort of trying to target a portion of the prostate. So HIFU is one of those. Cryotherapy, which we haven't talked about, is another treatment, sort of freezing of the prostate gland. In general, I think the overall consensus is that these have historically not achieved the levels of success that surgery and radiation do as primary treatment for prostate cancer. There are many studies and things that are being explored. Is there a particular category or scenario where they can be kind of good enough treatment? So, again, I'd sort of caution a little bit in saying, as you are exploring and looking at various options, making sure that you're going to, that multidisciplinary clinic, often in the academic or NCI, National Cancer Institute designated cancer center, where you're getting sort of what are the standard of care, what are the national guideline treatment recommendations to give you the best, chance or odds of success of cure of your cancer. And then you can ask the question of where this other sort of focal therapy or ablative therapy or a different type of therapy from surgery or radiation may fit into that conversation and whether it's appropriate.
Good. We're down to the last couple of minutes. Just some basic symptoms to be aware of, some signs and symptoms, for somebody listening and saying, I wonder if I need to go in. What are some, obviously we need to go and get screened. You're at a certain age, and you said, Dr. Brawley, that's 55 to 60?
No, 40. Well, first, when someone is 45, if they have no family history, no brothers, father, uncles with prostate cancer, at 45, they need to have a conversation with their doctor and make a decision as to whether they're going to commit to regular routine screening or whether they're going to decide not to get screened. The decision needs to be made at 45. But we need a good decision with good conversation beforehand with the doctor, and which means we all need to have a doctor. And let's not forget hypertension, diabetes, not smoking, not being overweight, and all these other things as well.
All right. Gentlemen, final thoughts. Just everybody, give me 30 seconds of your final words to our audience today, starting with Mr. Carey. 30 seconds.
One of the things that I would mention, and it was mentioned earlier, about how women will talk with each other about what's happening with them and will share what's happened between them and their doctors, and they'll rate doctors. My experience with that comes from work that I've done with ovarian cancer support groups. Men, we know, don't really do that, and we need to learn how to do that. But I don't know how to make that happen.
Thank you, sir. Dr. Yates?
Yeah, I think I'll just, sort of reiterate what I was saying before. Men, if you don't remember any of the terms we talked about today, some of the things, own your health, right? Go to the doctor. Own your health. It'll start to become clear as you go more frequently, and you'll start to get with some of the language in the terms and the words. But own your health. Don't be afraid to have a conversation.
Awesome. Dr. Brawley?
Yeah, I wish every man, every woman for that matter, had the opportunity to have discussions with a health coach on how to stay healthy and how to deal with all of these things. Unfortunately, our healthcare system doesn't allow for that. I will advise anyone who has an illness, I will advise them to try to have good conversations with your doctor and good, clear, open communications about what's going on with you, what questions you have. And if you can't have a good conversation with that healthcare provider, perhaps you need to find another healthcare provider.
Wow. So good. Dr. Deville?
Yeah, I mean, I echo that and just build on it. A lot of men I see, they had very high PSAs or they're sort of, further advanced than we want them to be. And I'll ask, was the prostate cancer being screened? And they'll say, I don't know, or things like that. And I say, if you don't know whether you were being screened or checked for prostate cancer, then you weren't being screened, because you should be having that conversation with your physician about the risks and benefits of screening. And so you should be clear on whether you're doing it or not. Don't assume that the physician is doing something. We really, as Dr. Yates said, need to be, advocates for our own health, and not sort of waiting or assuming. This is not the current era if we really want to have the best outcomes and eliminate those disparities in prostate cancer.
Awesome. I would just like to say in closing to each of you, thank you for the work you're doing to save lives. Thank you for the work you're doing as Black men for our community. Thank you for taking time out of your schedules today to just give us this information. This has been Straight Talk on prostate cancer, and we're overcoming these controversies and educating and empowering Black men. You all have done that today. I'm so honored to have been a part of it. And thank all of you all for tuning in today. And please spread this information to those you love. God bless everybody.